Welcome back to the deep dive. Today, we are shifting gears a bit. We're leaving the casual learning environment behind and actually entering a simulation. I want you to just close your eyes for a moment. Picture the scene. You're sitting in a wooden chair that's just a little too hard. The air conditioning is humming, that low, monotonous drone. And across the desk, there's a senior professor, silver hair, very serious expression.
The examiner.
You are the candidate. They are the examiner. This is the Gujarat University MD Anesthesiology exam.
That's it. Your heart rate is up, your palms are sweating, and there's definitely no multiple choice to save you now.
Exactly.
So today, we're really simulating a high-stakes prep session for one of the most classic, rigorously tested topics in the entire curriculum: restrictive lung diseases and bronchiectasis.
We've got the whole stack here. I mean, we've pulled out Miller's anesthesia, Morgan and McHale, Robbins pathology, Yao and Artuzio. Our mission is to take you from a basic understanding to the level where you can handle the short notes, the long answers, and, the dreaded Viva traps.
We have to. We're not just skimming the surface here.
Yeah.
We are drilling down into the why of the pathophysiology, the clinical features, and most importantly, the anesthetic management.
The how.
Exactly, the how. Because the examiner isn't looking for surface-level stuff. They want to know you get the mechanics of the, let's call it the stiff lung versus the septic lung. They want to see that you can keep these patients alive when their own physiology is fighting against you every step of the way.
Okay, so let's get straight to business then. Part A, introduction and exam framing. If I'm the student and the examiner asks me to classify the universe of lung diseases, where do I even begin without stumbling?
You start with the most fundamental division. It's right there in Robbins and in Morgan. You look the examiner in the eye, and you divide the entire respiratory world into two distinct categories.
Okay.
First, you have your obstructive lung diseases. This is your asthma, your COPD, your emphysema. The fundamental problem there is airflow limitation.
Air gets in but can't get out.
Precisely. Air gets in, but it struggles to get out, either because of airway resistance or a loss of that elastic recoil.
But that's not our focus for today. We're looking at the other side of that coin.
Correct. We are focusing on restrictive lung diseases. Morgan and Miller define this very specifically. They're diseases characterized by a reduced expansion of the lung parenchyma,
Okay.
which is accompanied by decreased total lung capacity, or TLC. The hallmark, the single word to remember, is decreased lung compliance.
In simple terms, the lungs are stiff.
They're stiff. The bellows are just hard to open. That's the perfect analogy.
Okay. And we're also covering bronchiectasis. Now, this is a point of confusion for a lot of students. Is it restrictive or is it obstructive?
And that is a classic Viva trap. You're right to ask it. Technically and pathologically, if you're quoting Robbins, bronchiectasis is primarily an obstructive pathology.
Oh, interesting.
Yeah, the definition is the permanent dilation of the bronchi and bronchioles. And this is caused by the destruction of muscle and elastic tissue, which results from chronic necrotizing infections.
So it's not a primary disease then?
No, it's secondary to obstruction or infection.
So why do we group it with restrictive diseases for this deep dive? It seems a bit counterintuitive.
It does, but there are two very good reasons. First, in the exam, you often see mixed presentations. A patient with severe bronchiectasis often has significant parenchymal fibrosis as well, which gives you that restrictive element.
Ah, so you can have both at the same time.
You absolutely can. And second, the anesthetic management is completely distinct, but equally critical. So while restrictive disease is the stiff lung, bronchiectasis is what I call the septic or wet lung.
Stiff lung versus wet lung.
And both of them require incredibly high-level management strategies to prevent a catastrophe in the operating theater.
Why is this specific pairing such a favorite for the Gujarat University exams? What makes it so high yield?
Because the margin for error is, well, it's basically non-existent. In restricted disease, your patient has almost no physiological reserve. Their functional residual capacity, their FRC, is tiny.
That's their oxygen tank during apnea.
It's their oxygen tank, and it's running on empty. They'll desaturate in seconds. And then in bronchiectasis, the patient is literally drowning in secretions. If you manage that airway poorly, you flood the healthy lung with pus.
A disaster.
An absolute disaster. The examiner needs to know that you understand those two distinct risks.
So how does this usually pop up on the exam paper itself?
You'll see it everywhere. In the theory papers, you might get short notes like, describe the flow volume loops in restrictive disease, or explain the pathophysiology of bronchiectasis.
The basics.
The basics, but you need detail. Then you'll almost certainly see long answer questions, the 10 to 20 markers. Things like, Discuss the anesthetic management of a patient with severe kyphoscoliosis, which is an extrinsic restricted disease, or pulmonary fibrosis.
And in the Viva?
Oh, in the Viva, they'll just hand you a PFT trace and say, interpret this, or they'll hit you with a scenario. You're in the OR, your restrictive patient is hypoxic. What do?
Okay, let's dive in then. Part B, restrictive lung diseases. We need a solid structure for this, something we can recall under pressure. So let's start with section 2, classification. How do we organize this?
The exam core classification. You have to divide it into 2 main buckets, intrinsic and extrinsic. This is the standard approach you'll find in Miller.
All right, let's break down intrinsic first. What does that mean?
Intrinsic, or you can call it perimal, means the pathology is inside the lung tissue itself. The lung tissue is sick.
Okay, so the lung itself is the problem.
Exactly. The classic example that everyone should know is idiopathic pulmonary fibrosis, or IPF. Then you have things like sarcoidosis and the pneumoconiosis, from dust inhalation.
Are there any specific causes we should drop in an answer to, impress the examiner, show we've read a bit more widely?
Absolutely. Always mention drug-induced fibrosis.
Yeah.
And you have to name the drugs.
Which ones?
Quote, bleomycin and amiodarone. Miller specifically highlights these as key causes of pulmonary toxicity that leads to fibrosis. If you mention those, it shows you're thinking about the patient's full medical and pharmacological history.
Good tip.
And also, don't forget ARDS. Acute respiratory distress syndrome is, for all intents and purposes, an acute intrinsic restrictive pathology.
Okay, so that's intrinsic. Now let's talk about extrinsic. This means the lungs are actually normal, but something else is wrong.
Exactly. Extrinsic or extrapulmonary means the bellows are failing. The lungs are being restricted from the outside.
And how do we subdivide that?
For the exam, think of it in 3 groups. First is the chest wall and pleura. This is your kyphoscoliosis, pectus excavatum, large pleural effusions, or pneumothorax.
The structural page.
Right. The second group is neuromuscular. Think Guillain-Barré, myasthenia gravis, or even high spinal cord lesions. The pump is weak. The muscles can't generate the force.
And the third group?
The third group is abdominal. This is anything that pushes up on the diaphragm. Severe obesity, massive ascites, or even late-stage pregnancy. It's a mass-loading effect that physically restricts lung expansion.
So when the examiner is asking about this classification, what are they really probing for? What's the underlying concept they want to see that I understand?
They want you to distinguish between lung compliance versus chest wall compliance.
Ah, okay.
Lung compliance is what's reduced in intrinsic disease. The lung tissue itself is stiff. Chest wall compliance is what's reduced in extrinsic disease. The chest wall or the abdomen is stiff or weak. Both will result in a restrictive pattern and a reduced total lung capacity, but the actual mechanics of why are different.
Got it. Okay, let's get into those mechanics then. Section 3, pathophysiology. This is exam gold, you said. Why is it so hard to ventilate these patients?
It all comes down to one word: compliance. You absolutely must know the formula.
Compliance equals change in volume divided by change in pressure.
Perfect. Delta V over delta P. And in restrictive disease, that pressure volume curve is flattened and, crucially, shifted to the right.
Shifted to the right. So if I'm picturing the graph, what does that mean in practical terms?
It means that for any given change in pressure you apply, you get a much smaller change in volume compared to a normal lung. You have to push much, much harder, generate more pressure, just to get a small amount of air in.
And why is that? In intrinsic fibrosis, what's causing that stiffness?
So Guyton explains this really well. It's due to increased elastic recoil. All that fibrous tissue, the scar tissue, it acts like a very stiff, heavy-duty rubber band. It's constantly trying to snap back and collapse the lung.
And this directly leads to the reduced lung volumes we see on the PFTs.
Across the board. Yao and Artuzia is very clear on this. Your total lung capacity, your TLC, is reduced. Your vital capacity, VC, is reduced. Your residual volume, RV, is reduced. Everything is smaller.
But there's one volume that's most critical for us as anesthetists.
The functional residual capacity, the FRC. This is, without a doubt, the most important one for us to worry about.
Because FRC is our buffer. It's the oxygen that's left in the lungs during apnea after we've given the muscle relaxant.
Exactly. It is your safety margin. And in these patients, the FRC is drastically reduced. So that means when you induce anesthesia and they stop breathing, you don't have minutes. You have seconds before they desaturate. It's a critical point.
So, given all this stiffness and the extra effort required, how does the conscious patient compensate? How do they manage to breathe?
They have to massively increase their work of breathing. Expanding a stiff lung requires an immense amount of energy. So as Miller points out, The body very cleverly adopts a specific breathing pattern.
The rapid and shallow breathing.
Rapid and shallow. It's a trade-off. It's metabolically more efficient for them to take small, frequent breaths than it is to fight against that high elastic recoil to take a deep breath.
So it's a compensatory mechanism, not just a sign of distress.
It's an incredibly smart compensatory mechanism.
Okay, let's move on to gas exchange. Section 4. Is this purely a problem of moving air, a ventilation problem, or does the actual gas exchange at the alveolar level suffer too?
Oh, it suffers significantly. And Miller emphasizes this. The primary cause of hypoxemia in these patients is VQ mismatch. That's ventilation-perfusion mismatch.
Can you unpack that for us? What's happening?
Sure. So in fibrosis, you have these scarred, stiff areas of the lung that are very poorly ventilated. Air isn't getting to them. However, the heart is still pumping blood to those areas. They're still being perfused.
So you have blood flow, but no air.
Exactly. You have perfusion without adequate ventilation. This creates a low VQ ratio, and it acts just like a physiological shunt. Deoxygenated blood passes through the lung and goes back to the left side of the heart without ever picking up oxygen.
Okay, that makes sense. Is there also a diffusion problem? I remember reading about that.
Yes, there is, specifically in intrinsic fibrosis. Robbins describes how the alveolar capillary membrane itself becomes thickened with scar tissue. Oxygen physically has a harder time traveling from the alveolus into the red blood cell.
Right.
Now, here is a very high-yield exam detail. That diffusion limitation usually only becomes clinically apparent during exercise.
Why specifically during exercise? That's an interesting point.
At rest, the red blood cell spends just enough time in the capillary to get fully oxygenated, even with that thick wall. It's slow, but it gets there. But during exercise, your cardiac output goes up and blood flows through the lungs much faster.
The transit time is shorter.
The transit time is reduced. And now, the oxygen simply doesn't have enough time to diffuse across that thickened barrier before the red blood cell is gone. And that's when the patient desaturates.
That's a brilliant clinical pearl. What about carbon dioxide? We've talked a lot about oxygen. Is PeCO2 high?
You'd think so, but interestingly, the PeCO2 is usually normal, or sometimes even low in the early stages.
Why low?
Because the patient is hyperventilating due to the hypoxia. They're breathing fast to try and get more oxygen in, and that blows off CO2. And remember, CO2 is about 20 times more soluble than oxygen, so it diffuses out very easily, even across a thickened membrane.
So you wouldn't see hypercarbia until the very end stages.
Exactly. You typically don't see a rising PaCO2 until the patient is in terminal respiratory failure, or the restriction is just so severe that they physically can't move enough air anymore.
Okay, let's try and visualize this patient walking into the pre-op clinic. Section 5, clinical features. What are we seeing and what are we hearing?
The number one symptom you're going to hear about is dyspnea, shortness of breath.
Yeah.
And it's progressive and primarily exertional.
Gets worse over time.
Yes. And in intrinsic disease, they often have a very characteristic dry, non-productive, irritating cough.
And on the physical exam itself, what are the key findings?
Well, first you'll see the tachypnea, that rapid, shallow breathing we just talked about.
Yeah.
Then you need to listen to the chest. Listen for the Velcro crackle.
Velcro crackle.
Yeah, Harrison describes them perfectly. They're these fine inspiratory crepitations, usually at the lung bases. It literally sounds like you're pulling apart a piece of Velcro. It's from the sudden opening of those stiff, fibrotic airways.
That's a very vivid description. Anything else we should be looking for?
Yes, look at the hands. Look for clubbing of the fingers, which is very common in IPF. And critically, you must check for signs of cor pulmonale.
Right. Heart failure from the lung disease.
Precisely. Chronic hypoxia causes pulmonary vasoconstriction, which leads to pulmonary hypertension. So you need to look for a loud P2 heart sound, check for jugular venous distension, the JVD, and look for pedal edema. Finding that changes your whole anesthetic plan.
Okay. Now for what might be the most important part for the exam. Section 6, pulmonary function tests. The PFTs, you said if you can't read these, you fail the station. So
good.
Let's break it down. What are the numbers we're looking at?
Okay, first, look at the absolute volumes. Your FVC, the forced vital capacity, is going to be reduced, and your FEV1, the forced expiratory volume in 1 second, is also going to be reduced.
So both are down. That sounds like it could also be obstruction. How do we distinguish this from, say, COPD?
The ratio. The ratio is everything. This is the absolute key.
The FEV1-FVC ratio.
Yes. In restrictive disease, remember how we said the stiff lung tissue has high elastic recoil? Well, that recoil actually pulls the airways open. It's called radial traction. So the airways aren't floppy or narrow.
Okay.
Because of that, the flow rates are actually pretty well preserved relative to the small lung volume. Therefore, the FEV1-FVC ratio is normal or even high. It's going to be greater than 70 or 80%.
That's the headline takeaway then. Obstruction means a low ratio. Restriction means a normal or high ratio.
If you remember nothing else about BFTs, remember that. Now, the next number to look at is the DLCO, the diffusion capacity. This is what helps you distinguish intrinsic from extrinsic disease.
How so?
In intrinsic disease, like fibrosis, the alveolar capillary membrane is sick. It's thickened. So the DLCO will be reduced.
It makes sense.
But in extrinsic disease like kyphoscoliosis or obesity, the lung parenchyma itself is normal. The problem is outside the lung, so the DLCO is often normal. That's a key Viva differentiator.
Okay, and last piece of the puzzle, the flow volume loop. I'm standing at the Viva whiteboard. The examiner says, draw it. What do I draw?
You draw the witch's hat.
The witch's hat.
Yes, it's a tall and narrow loop. Think about the axes. It's narrow because the volume, which is on the x-axis, is reduced. The total amount of air is small.
And why is it tall?
It's tall because the peak expiratory flow on the y-axis is preserved, or sometimes even higher than normal, because of that high elastic recoil we talked about. It just snaps the air out quickly. And the descending limb is very steep and straight.
As opposed to the scooped out or coved appearance you see in obstruction.
You've got it. That's the perfect description.
Okay, fantastic. We have the diagnosis. We understand the pathophysiology. Now we move to the core of our specialty. Part C, anesthetic management of restrictive lung diseases. Let's start with Section 7, the preoperative assessment.
The whole goal here is to assess the patient's reserve. And the best way to do that, honestly, is functional capacity.
So the classic, can they climb 2 flights of stairs?
Exactly. Can they climb stairs? Can they walk down the hall? If they are dyspneic at rest or with just minimal exertion, they are extremely high risk, and you need to be very, very careful.
How do we optimize them before surgery? Is there anything we can do?
You have to treat any reversible elements. If they have a superimposed respiratory infection, you treat that with antibiotics. If they have a large pleural effusion or massive ascites that's causing an extrinsic restriction, Miller suggests you should consider draining it preoperatively to improve their mechanics.
What investigations are absolutely non-negotiable?
You need a fresh chest x-ray, or even better, a CT scan, to really assess the extent of the fibrosis. You're looking for that honeycombing pattern. You need an ABG, an arterial blood gas, to establish their baseline hypoxia and see if...
All right. Section 8. Intraoperative anesthetic considerations. This is very high yield. Let's talk about the choice of anesthesia.
If the surgery allows for it, regional anesthesia is often the preferred choice.
Why is that?
Well, you avoid airway instrumentation, you avoid positive pressure ventilation, and the patient can maintain their own respiratory drive. However, you have to be extremely careful with the level of the block.
Why? What's the risk with a high spinal, for example?
Remember how these patients depend on their accessory muscles for that rapid, shallow breathing pattern? A high spinal or a dense epidural can block the intercostal muscles. If you knock out their intercostals, you've taken away one of their main compensatory mechanisms, and they might suddenly decompensate and stop breathing effectively.
Okay, so a huge caveat there. If we must use general anesthesia, what's the most critical part of induction?
Pre-oxygenation. It is absolutely critical. I can't stress this enough. Because of their reduced FRC, they have almost no oxygen reserve. They will desaturate frighteningly fast. You need to give them 100% oxygen for at least 3 to 5 minutes of tidal breathing before you give any induction agent.
And the ventilation strategy, you said this is where students often make mistakes.
They do. The biggest mistake is to use standard tidal volumes. You cannot try to push 500 or 600 milliliters of air into a stiff, fibrotic, baby-sized lung. If you do, you will generate massive peak airway pressures.
Which leads to?
Barotrauma.
Yeah.
Pneumothorax. Or volutrauma, which is ventilator-induced lung injury. You're literally tearing the lung tissue.
So what is the safe exam-winning answer for the ventilation strategy?
You must say you will follow the principles of lung protective ventilation. That means small tidal volumes. Specifically, 4 to 6 milliliter per kilogram of predicted body weight.
Predicted, not actual. That's an important distinction, especially in an obese patient.
A critical distinction.
But with such small volumes, the CO2 is going to rise. How do we manage that?
Right. To compensate, you must increase the respiratory rate. You're aiming for a rate of maybe 14 to 20 breaths per minute, sometimes even higher, to maintain an adequate minded ventilation and keep the CO2 in check. We call this permissive hypercapnia, if we have to let the CO2 rise a bit to protect the lungs.
What about PEEP?
Use PEEP cautiously. A small amount, say 5 to 8 centimeters of water, can be very helpful to prevent atelectasis and keep alveoli open. But excessive PEEP in a stiff lung can overdistend the healthier parts of the lung and compress the pulmonary capillaries, reducing cardiac output. It's a fine balance.
And volume control versus pressure control ventilation.
Many would argue that pressure control ventilation is superior here. It allows you to set a maximum peak inspiratory pressure, which directly protects against barotrauma. You set the pressure limit, and the machine delivers whatever tidal volume the lung will accept at that pressure.
Okay, the surgery is done. We're moving to recovery. Section 9, postoperative and ICU care. Are we out of the woods yet?
Absolutely not. The immediate post-op period is probably the time of greatest risk for hypoxia.
So what's the first thing we do?
Positioning. It's simple, but it's key. Sit the patient up. Get them in a head-up or semi-Fowler's position as soon as they are stable. This allows the diaphragm to descend, it offloads the weight of the abdominal contents, and it maximizes their already tiny FRC.
What about pain control?
Effective analgesia is vital. If it hurts to breathe, they simply won't. They'll splint, take tiny shallow breaths, and develop atelectasis and pneumonia.
So opioids might not be the best choice because of respiratory depression.
Exactly. This is where epidural analgesia or other regional techniques really shine. They provide excellent pain relief right at the source without the systemic respiratory depression you get with intravenous opioids.
And if they start to tire out?
You need to have non-invasive ventilation on standby, have CPAP or BiPAP ready to go. If you see their respiratory rate climbing, if they're using accessory muscles, put them on NIV early to support their work of breathing and prevent them from tiring out completely and needing reintubation.
Okay, let's pivot now. Let's shift gears completely to the other half of our topic. Part D, bronchiectasis, the septic lung.
The septic or wet lung, yes.
Section 10, definition and etiology. How do we define this for the exam?
So if you're quoting Robbins, you say, it is the permanent dilation of the bronchi and bronchioles. And that dilation is caused by the destruction of the muscle and elastic tissue in the airway walls, which results from chronic necrotizing infections.
What are the main causes we should mention?
You can group them into 3 categories again. First, infections. Tuberculosis is a major one for the exams, especially in our setting. Also, things like staphylococcus, adenovirus, or even severe influenza can trigger it.
Okay.
Second is obstruction, a foreign body that's been retained, or a slow-growing tumor that blocks an airway. And third is congenital conditions. The 2 big ones are cystic fibrosis and Cardigan syndrome, which is part of the motile cilia syndromes.
All right, section 11, pathophysiology. What's the underlying mechanism here?
It's what we call a vicious cycle. The initial insult, whether it's an infection or obstruction, destroys the cilia. This leads to impaired mucociliary clearance.
So the escalator that normally carries mucus out is broken.
It's completely broken, so mucus just pools in these now dilated, flabby airways. It has nowhere to go.
And stagnant mucus is never good news.
It's a perfect petri dish. It becomes a culture medium for bacteria. This leads to chronic infection and inflammation, which in turn releases enzymes that destroy more of the airway wall, which leads to even more dilation and more mucus pooling.
The vicious cycle.
It's a feedback loop of destruction. And for us, the anesthetic relevance is simple. This is a wet lung. Secretion management is your number 1, 2, and 3 priority.
Let's talk about how that patient presents. Section 12, clinical features.
It's a very classic picture. A chronic productive cough with copious purulent sputum. And when we say copious, we're not talking about a teaspoon. We're talking about cupfuls every day. And it's often very foul-smelling.
And bleeding. I remember that being a feature.
Yes. Hemoptysis is very, very common. Because of the chronic inflammation, the bronchial arteries that supply the airways hypertrophy. They become large and tortuous and very fragile. They bleed easily. A massive hemoptysis is a life-threatening emergency in these patients.
Okay. Section 13, investigations. How do we confirm the diagnosis?
The gold standard imaging is a high-resolution CT scan, an HRCT. You don't just want a regular chest CT. On the HRCT, you look for the classic Signet ring sign.
The Signet ring?
Yeah, it's where you see a cross-section of a dilated bronchus that is significantly larger than its adjacent pulmonary artery. It looks just like a Signet ring. That's pathognomonic.
And what other tests are essential?
Sputum culture. It is absolutely essential to guide your antibiotic therapy. You need to know what bugs are growing in there, and you have to specifically look for nasty ones like Pseudomonas or other resistant organisms.
Okay, now for the main event. Part E, anesthetic management of bronchiectasis. Section 14, preoperative preparation. What is the single most important step we must take?
Control of secretions. I'll say it again. You cannot, under any circumstances, take a wet, productive patient to the operating theater for an elective procedure. You must optimize them first.
And how do we do that? What does optimization look like?
It's a multi-pronged approach. First, intensive chest physiotherapy. That means postural drainage, percussion, vibrating vests for days before the surgery if possible. Second, you start appropriate culture-guided antibiotics to reduce the bacterial load and the purulence.
Any role for other medications?
Yes, bronchodilators if there's a coexisting reversible obstructive component, sometimes mucolytics. The entire goal is to bring the patient to the OT as dry as you can possibly get them.
Okay. Section 15, intraoperative management. The patient is on the table. What is the absolute nightmare scenario we're trying to prevent?
Contamination. Soiling. The risk is that during induction, or when you're positioning the patient, all that pus and infected material from the bad lung spills over into the healthy good lung.
Which would cause a terrible pneumonia or acute hypoxia right on the table?
Exactly. It can be an unrecoverable situation.
So how do we manage the airway to prevent that?
You need lung isolation. This is a mandatory mention in any long answer. For severe unilateral disease, you must use a double lumen tube, DLT, or a bronchial blocker. This allows you to completely isolate the infected lung, ventilate only the healthy lung, and protect it from spillage.
What about induction itself?
You should strongly consider a rapid sequence induction RSI. These patients are often swallowing large amounts of sputum constantly, so you have to assume they have a full stomach and are at a very high risk for aspiration of both gastric contents and their own secretions.
And once they're intubated and isolated, what's the plan for ventilation?
Frequent, and I mean frequent suctioning is required, often through the bronchial lumen of the DLT if you're using one. You must humidify the inspired gases. Yes. Avoid nitrous oxide. In patients with bronchiectasis, they can have large air-filled bullae or cysts. Nitrous oxide is more soluble than nitrogen and will diffuse into those closed spaces, expand them, and potentially cause them to rupture, leading to a pneumothorax.
Okay. Section 16, postoperative management.
It's all about getting back to basics. You have to resume their chest physiotherapy immediately in the recovery room. Encourage them to cough and clear their own secretions.
And again, pain control is key for that.
Absolutely. Effective coughing is mandatory.
Yeah.
And again, regional analgesia, like an epidural, is far superior to opioids because opioids will suppress their cough reflex, which is the last thing you want.
Let's do a quick comparison now to tie all this together. Part F, comparison and differentiation. Section 17. Let's put restrictive and obstructive disease side by side.
Okay, let's build the table verbally. First, mechanics.
Okay, mechanics. Restrictive is low compliance, stiff.
All right. Obstructive is either high resistance, from narrow airways like in asthma, or very high compliance, meaning floppy, like in emphysema.
Got it. Next, PFTs.
We covered this. Restrictive, normal or high FEV1 FVC ratio, but a low TLC. The overall lung size is small.
Obstructive, low FEV1 FVC ratio, that's the hallmark, and often a high TLC due to air trapping and hyperinflation.
Perfect. And finally, the flow volume loop.
Restrictive is the tall, narrow witch's hat.
And obstructive is the broad, scooped-out loop with a coved expiratory limb.
Excellent. Now, Section 18, a more nuanced comparison. Bronchiectasis versus COPD. They both can have an extractive pattern. They both cough. How do we tell them apart?
Okay, the big differentiator is secretions. In bronchiectasis, you have copious, purulent, often foul-smelling sputum. We're talking cups full. In COPD, the sputum is usually less and less purulent unless they're having an acute exacerbation.
What about the underlying pathology?
Very different. As per Robbins, bronchiectasis is that permanent dilation and necrosis of the larger airways. COPD is either acinar destruction at the level of the alveoli, which is emphysema, or mucus gland hypertrophy in the bronchi, which is chronic bronchitis. Different parts of the lung are affected.
Finally, let's get to the most practical part. Part G, exam integration. Section 19, common exam questions and Viva traps. What are the big mistakes that students make?
Okay, trap number 1, the ventilation trap. The student sees a sick lung and defaults to a standard ventilation setting, using 500 milliliters of tidal volume in a patient with severe fibrosis.
Which, as we said, is a disaster.
It's a disaster. The safe answer is, I will use a lung protective ventilation strategy with 4 to 6 milliliters per kilogram of predicted body weight, and I will limit my peak airway pressures.
Okay. Trap number 2.
The secretion trap. Intubating a wet bronchiectasis patient with a standard single lumen tube without any plan for isolation. You induce them, you position them, and you flood the good lung. Game over.
So the safe answer is always lung isolation with a DLT or bronchial blocker.
Always in severe unilateral disease. Trap number 3 is a bit more subtle, the closing capacity trap.
Okay, explain the closing capacity trap. This sounds advanced.
It is, but it's a gold medal answer in Viva. So closing capacity is the lung volume at which the small dependent airways begin to close during expiration. Normally, this volume is well below your FRC. You never reach it during normal tidal breathing.
Okay.
But in restrictive disease, the FRC is severely reduced. In many cases, the FRC can actually fall below the closing capacity. This means that airways are closing during every single normal tidal breath.
Which creates a massive VQ mismatch and hypoxia.
A massive shunt. And general anesthesia makes FRC even lower, which makes the problem even worse. Explaining that mechanism shows a really deep level of understanding.
That's a great point. Okay, section 20, diagrams and exam presentation. What should we be ready to draw?
You need to be able to draw 3 things. First, the flow volume loops. Draw a normal one, then overlay the obstructive and restrictive patterns on top of it. Always label your axis flow on the y-axis, volume on the x-axis. Second, the compliance curve. Draw the normal sigmoid curve. Then show the restrictive curve shifted to the right and flattened. And for contrast, show the emphysema curve shifted to the left and much steeper. Again, label the axis volume versus pressure.
And if I get a 20-mark question on anesthetic management, how should I structure it?
Classic structure. Preoperative, intraoperative, postoperative. Under preoperative, you must have assessment, investigations, and optimization. Under intraoperative, talk about monitoring, induction, airway, maintenance, ventilation, and emergence. And under postoperative, cover pain, oxygen, physiotherapy, and complications. Use headings. Keep it clean.
Perfect. Last section, section 21, summary and exam conclusion. Let's wrap this all up. Give us the rapid-fire, high-yield bullet points.
Okay, here are your 15-second takeaways for the exam.
Restrictive equals low volumes, low compliance, normal ratio.
Always classify into intrinsic, which is fibrosis, and extrinsic, which is chest wall or neuromuscular.
The core pathophysiology is stiff lungs, leading to rapid, shallow breathing and a VQ mismatch.
PFTs show a witch's hat loop. A reduced DLCO points to intrinsic disease.
The anesthetic plan is pre-oxygenate, use small tidal volumes, 4-6 millilkilograms, a high respiratory rate, and be cautious with PEEP.
Bronchiectasis is the wet lung. The biggest risk is contamination of the healthy lung.
Management is all about preoperative physiotherapy and intraoperative lung isolation with a DLT and RSI.
The perfect concluding sentence for your exam answer is, safe management of these complex patients relies on a thorough understanding of their pathophysiology, specifically recognizing the reduced functional reserve in restrictive disease and managing the significant contamination risk in bronchiectasis.
That is your deep dive for the Gujarat University MD exams. We have covered the stack. Now all that's left to do is go crush that Viva.
Remember, knowledge is safety. Good luck.